Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Your discretion is strongly recommended, and today we will be discussing as to how to use the iris hooks in case of small pupil. So 1 to 1.5 ml of lignocaine is injected in the subtenon space, as we will be handling the iris with the iris hooks, so it's better to give some form of anesthesia. A bit of phenocane is injected intracameral, but the pupil size remains the same. Now the dye is applied underneath the air bubble. Care is taken to inject some dye below the iris so as to get a good stain. Even with viscomydriasis, the pupil seems to be around 4.5 to 5 mm. The patient is hypertensive and I am expecting the pupil to go down as the surgery is proceeded. By now the triplanar incision is made with the 5.5 mm marker. We can see that the pupil is approximately 4.5 mm in size. Now 4 stab incisions are made. The direction of the side port should be downwards towards the iris. Now one by one these iris hooks will be placed, first at around 7:30 clock hour. The iris hook is gently taken inside the eye. The silicone guard is then pulled backwards and the iris is gently hooked. Care should be taken to be gentle so as not to injure the anterior capsule. And once the iris is hooked, the silicone guard is pulled forwards. Care should be taken not to overstretch the iris at the very first go. Now the second iris hook is being placed. And the guard is then gently drawn towards the limbus. Now the third iris hook. Approximately at 1:30 clock hour. Holding the guard often gives better control of the hook. As you can see, I am not overstretching the iris at the moment. And finally the last hook at approximately 4:30 clock hour is placed. Now holding the guard, the guard should be pulled backwards so as to create more space, and then slowly the iris hook is tightened, and now the iris hooks are tightened a bit further to get a good exposure. and I am getting almost a square shaped exposed anterior capsule, and this should work. So we have made these two at approximately 10:30, 1:30, 4:30 and 7:30 o'clock hour. The two iris hooks closer to the main incision are made approximately 1.5 clock hours away, so that the tenting of the iris is less and there is ease of taking the instruments from the main port, mainly the probe. If we make the incisions further away from the main port, then the tenting of the iris is more, and thus taking the probe inside the eye might injure the iris. Now we have done the hydrodissection. Now the video has been sped up. These iris hooks hold pretty well, and we can do almost all the maneuvers inside the eye very easily. Because the iris is lifted up a bit, taking in the probe gives the feeling as if we are taking the probe in a hypermetropic eye. But once you reach the nucleus, then you find that there is adequate depth to work on the nucleus. So we'll be doing a stop and chop, and you can see even when I'm moving the eye, the iris hooks are pretty stable. Now the central trench is being made. This is a grade 3 nucleus and should crack easily. Nucleus is rotated and the groove is extended to the other side. Once the adequate depth is achieved, the crack is made. Now the heminucleus is then held and chopped. The other heminuclei is then brought forwards by rotating, held and chopped. So now we have 4 quadrants which are then slowly emulsified. The probe should be kept in the central safe zone so as to minimize damage to the endothelium, and by now the one heminucleus is emulsified. The 4th quadrant is also then slowly emulsified. So as I have a good exposure to the nucleus and the cortical matter, I am able to manage the nucleus easily. So always I would recommend to use a pupil expansion device. In case of a small pupil, it gives a better visibility and more confidence. Now the cortical matter is then washed out. At 12 o'clock or the subincisional cortex should be cleaned by going through the side port. The chamber is deep and the accessibility is easier, and we are able to take up almost the whole cortex. So now is the time to take the IOL and inject it inside the anterior chamber. But before that, I prefer to remove the 2 iris hooks closer to the main incision because they are lifting up the iris, and if I do a wound assisted IOL implantation, there are chances I would injure the iris. So once these two iris hooks are removed, suddenly the chamber deepens in the subincisional area. The other two at the moment are left as it is, so that I get good visibility while injecting the IOL and making sure that the IOL goes in the bag. And now a bit of viscoelastic substance is used over the cornea to increase visibility, and the wound assisted hydrophobic intraocular lens is then injected. The leading haptic goes in the bag, and then the trailing haptic is gently dialed in. And now is the time to remove the remaining two iris hooks. Gently pull the guard back, rotate the iris hooks, and it comes out. Gently twist and take it out. And now is the time to thoroughly wash the anterior chamber. So the take home message is, when in doubt or when the pupil is small, always take help of any pupil expansion device. For beginner surgeons, iris hooks are pretty easy to use. They are surgeon friendly. And it's a saying, don't perform a surgery if the visibility is not good. All the surgical steps should be done under a good visibility. So finally the case is almost done. Now is the time to hydrate the wounds and a gentle hydration of the stab incisions. There is no need for over hydration. Just a gentle hydration is enough to heal and close these small wounds. So this is the final case at the end. Let's see the post-op day 1 slit lamp photo video. A bit of keratitis is there, but then that is acceptable. Do it next time. Thanks for watching.